Hello, everyone. Thank you for joining us today and welcome to Family Day. Today's panel discussion is on the pandemic lessons learned, what the future holds. My name is Esteem Brumfield. I'm an MPH candidate at the School of Public Health. And today I'm joined by Dr. Ashish Jha, Dean of the School of Public Health, Professor of Health Service Policy and Practice. And we're also joined by Dr. Megan Ranney, Emergency Physician at Alpert Medical School, Director of Brown Lifespan Center for Digital Health, and Associate Dean for Strategy and Innovation at Brown School of Public Health. Thank you for joining me today.
Thank you so much for having us here.
Thank you, Esteem.
I'd like to begin today's discussion just quickly addressing what President Paxson had mentioned in some of her remarks during her panel session today. She highlighted what the university is doing in terms of keeping students safe and her vision for opening campus in the fall and this coming summer. And she spoke to where we're at in terms of controlling the pandemic at the university level. Dr. Jha, I was hoping we could start with you and maybe you could speak to where you think we are in terms of the national level. If you could provide us a snapshot.
Absolutely. And again, really delighted to be here with all of you. Thank you for having me here. First day of spring. And I think in some ways, that is the analogy that really, I think, captures where we are at this moment. What we know in New England is that when you hit the first day of spring, you're not done with winter. We still get the occasional snowstorm. We still get some cold days. So we don't put away our jackets and get ready fully for summer. We have to hold on a little bit longer. Really feel like that's where we are as a country right now. We have about 50,000 infections still happening every day. The variant that concerns a lot of us, the B.1.1.7, originally from the UK, is widespread. Probably half of all infections in America are from that variant and probably be close to 90% of all infections within the next couple of weeks. What that has done for Europe is really flattened Europe. I mean, you see huge increases in cases in many places in Europe. I think we're going to avoid that. And the way we're going to avoid that is by keeping restrictions in place for a little longer and keeping going on vaccinations. So I'm very optimistic about late spring, summer, but I remain pretty anxious about where the next 4 or 6 weeks are going to be. And that's the time period that we really need to get through.
Thank you for that. And Dr. Ranney, I wanted to bring you in. Could you give us a snapshot of where public health practitioners, first-line responders are in terms of the pandemic? What are our hospitals looking like around the country?
Yeah, so great question. And again, thank you, Esteem, in particular, for being willing to moderate us today. Really appreciate it. As one of our MPH students, it's a delight to have you here managing this conversation for us. So I actually worked last night in the ER at Rhode Island Hospital, and I'll be going back again tonight. And I can tell you that we are in such a better space than we were even a month ago. And certainly it's a dramatic difference from where we were in late January, early February. We've seen the burden of COVID on hospitals across the country decreased dramatically. And importantly, we've also seen the burden of COVID on staff decrease dramatically. Back in January and February, before most of us were vaccinated, we were having multiple call-outs. We were consistently short-staffed because so many of us were getting sick, either at work when we were in the healthcare facility or in the community, because many of us were exposed to the same stuff that everybody else was. That has gone away since most of us have been vaccinated at this point. We are, of course, still seeing COVID, as Dean Jha just mentioned. Just last night alone, I took care of a couple of folks that got admitted to the ICU. It has not disappeared, but it is not the overwhelming crush that we had earlier. And again, the other really amazing part right now is that we no longer have that deep fear of being infected ourselves and of bringing it home to our family, thanks to vaccinations.
Yeah, that I think is key, that point. And I wanted to transition into some of the lessons that we've learned around race and equity in terms of the pandemic and in terms of quality of care, as well as innovation and how we've rolled out the pandemic in communities of color. Is it too soon to say what progress we think we've made and how we can expand and build upon that?
Do you want me to start?
Go for it, Ashish.
Sure.
Yeah. So, look, this pandemic has not affected all of us equally by any stretch. We know it has disproportionately impacted communities of color, Black and Latino communities across the country, Native American communities as well. And that effect has been both in infections, but also in hospitalizations and deaths. And it's really a two-part thing, right? It's both who got infected in terms of who were the essential workers, who lived in multi-generational housing, and then who actually died after infection. And that has every bit as much to do with where was testing available, what kind of quality of care did people get in the hospital once they arrived, which hospitals disproportionately cared for minority patients. It's a whole set of factors. I think we're still unpacking that, and we're going to have to make some very serious investments in our country in making sure that we address those underlying issues. But then if you flip it to now coming out of the pandemic, vaccinations, the vaccinations are a mirror image of what happened. So now Blacks and Latinos are actually much less likely to be vaccinated than white Americans. And there's a whole host of factors that go into it, but the communities that are being hit the hardest are the ones that are least likely to get vaccinated. Seems like a huge problem, and it is. And I think there is some effort being done across states, and some states more than others, to try to address this, but we're nowhere near where we need to be in that effort. And we can get more into details on what we need to do, but we're certainly not anywhere near equity on the issues of vaccinations. And I worry that that's going to be something that's going to continue to plague us for the weeks and months ahead.
Yeah, I'm just going to kind of echo off of that to say that to kind of the problems that we have seen during these pandemic are nothing new. Any of us that work in public health or healthcare have known that there have been issues with structural racism and inequities in the way that we deliver healthcare and public health that go back to the beginning of our country. What is different is that we're paying attention to it a little more closely. And so, I and Dr. Jha frequently say that this pandemic has really ripped the Band-Aids off of all of the little solutions that we were putting to try to help folks who were otherwise being left behind, suffering from poor health. You only have to look at maternal mortality rates, diabetes rates, life expectancy for Black and Brown communities to know that this is not new, right? It's just magnifying the problems that were already there. And so I know in the pandemic problem solving course that the two of us are co-leading, we've talked a lot about how we can take this pandemic as an opportunity to put the investment, as Dean Jha just said, and the attention towards these issues that they have deserved for a long time and that many folks have been talking about, but they just weren't being listened to. And so that may be one, hopefully, silver lining out of the pandemic, is that it could be the driver for us to finally collect and look at accurate data and to address the underlying drivers of those inequities in a way that we really haven't had the opportunity to do before because of lack of political will.
Dr. Ranney, I want to stay on that point. From your point of view, how can we continue to build on that momentum, continue to do that work? Oftentimes, a lot of folks in the country feel like we have a short attention span as a people and we're on to the next topic. But how can we continue to collectively build the momentum to address race and equity?
I love that question. So, of course, this, being a professor here, my first answer is going to be kind of training the next generation. And I really look at the work that our students and recent students are doing, their unfailing commitment to calling out this issue, to maintaining an eye on this data and on these inequities, I think is one of the most important things that we can do. But then I also think it's on people like me and Ashish to take, we have a relative position of privilege. Is kind of our leadership roles at Brown, as physicians, as public health professionals. And I think it's on people like us to continue to raise the issue. We can't say that this is the problem of minority or low income or kind of otherwise vulnerable communities. It has to be on those of us who do kind of hold some privilege and power to say that we're going to keep an eye and a lens on this. And then the last part, of course, is advocating for funding. Anything, we can listen, we can talk about the data, but the solutions take money. And we've seen the tremendous success in developing vaccines, thanks to the investment of money. We've seen the failures in the logistics of delivering the vaccines due to lack of investment of money. At the same time, we're better off in many ways than Europe is because we've invested more there than the Europeans at this point. But it does take those funds and that investment, and that's going to take public-private partnership. It's going to take improved research to identify the best ways to address these. There's some really innovative stuff being done both here and elsewhere, but it's going to be that multi-pronged approach that's going to bring us forward, and we just can't let up on making sure that it's always part of the discussion.
Yeah. And Dean Jha, if you could speak to what you believe the future will look like moving forward. What do you envision this new normal, as a lot of folks tend to call it, to look like in the coming year?
Yeah. So one of the questions I often get asked is, when do we go back to normal? And my first question is, by normal, do you mean 2019? And that's what people usually mean, what life was like in 2019. And my kind of glib answer, and I don't want to be glib about this, but I do want to sort of make the point, we're never going back to 2019 because pandemics change societies. And we also should not mourn the fact that we're never going back to 2019, because there's no reason to believe that 2019 needs to have been our most glorious year. There are lots of opportunities for having a 2021, a 2022 that is meaningfully better. So how do I sort of see the next year or two playing out? First of all, I will say that it's hard in some ways to know what life will look like 5 years from now. Pandemics change societies, but often in unpredictable ways. But there is a lot we can do to shape what that future is going to look like. So I expect this summer, just to kind of start short term, I expect this summer to be terrific. I expect this summer to have relatively low levels of infection, high levels of immunity across the population. The fall and winter, I expect the fall to begin pretty normally. This is looking more and more like a seasonal virus. So I do think, at least in the Northeast and northern part of the countries, we're going to see a bump in cases in the late fall and winter. And we should just be ready for that with lots of testing and lots of kind of other policies ready to go. I don't expect massive disruption, but I can imagine little things. I can imagine a little spike in cases and the mayor of Providence comes out and says, hey, for 2 weeks, indoor mask wearing for, in retail shops, or for 4 weeks or something, where you have these kind of temporary interventions and maybe a bit of a de-densification of restaurants and other things that help get people through these little mini surges. I think once we get into next year, we should be in relatively good shape. We're probably going to have to update our vaccines. We're probably going to have to make other changes. But we're going to settle into what should feel like a new normal. And maybe that new normal means no 500-person indoor, lecture halls. I don't know if that's the worst loss in, history. Maybe those will be done kind of more virtually, and classrooms will really become places where small groups gather for engaging conversations and discussions. So I think we're going to discover new ways of being together and spending time together. But I'm certainly actually pretty optimistic about the future. I don't know that I'm going to miss 2019 by the time we get to next year.
Sure, yeah, I'm with you. I'm also optimistic. But in keeping with that, I wanted to piggyback off of that, Dr. Ranney. You addressed this in your problem solving course, the pandemic problem solving course, about what a new normal could look like in terms of mental health. A lot of frontline workers are still grappling with the pandemic and the devastation that has caused, both in their personal lives, their professional space. Could you talk a little bit about what we should be mindful of as we construct an idea of a new normal? How can families also be a support service for their students in terms of mental health and well-being?
Yeah, Esteem, I love that question. Thank you. I think it's really important to take a moment or longer than a moment to grieve all that we have lost in the last year. Certainly, many of us have lost friends or loved ones from COVID. And even though for those who haven't, we've lost many milestones, particularly for our college-aged students, right? These 4 years to someone, my and Ashish's age, 4 years feels a little less significant, but to lose your entire first year in person, to lose campus dance, those can be huge losses. I've got 2 school-age kids myself, and I know, for my daughter losing her 5th grade graduation was a really big deal. And I think giving ourselves moments to grieve both the big and those things that may seem littler or less significant than a loss of life, still allowing us to admit that it was a loss. That's important. For those who are working in healthcare, we've been going full out for the last year, have faced a number of both emotional and physical challenges, starting with the lack of personal protective equipment early in the pandemic, through seeing many of our colleagues get sick and some of them die during kind of the middle part where we still weren't completely clear on how this got transmitted. And then the frustrations of the fall and winter, where again, as vaccinations started to come out, we've been less likely to get sick, but are dealing with the real kind of disconnect between what we do in healthcare and kind of what's going on sometimes in the rest of society, particularly in some states where there have been fewer regulations around mask wearing and social gathering. And I think one of the things that's going to be important for us in healthcare, but probably for everyone else as well, is to recognize it's like, I'll often tell people in the ER after a car crash, you don't really feel a lot of pain necessarily right after a minor car crash or even a major one, unless you've broken a bone. It's the next day or two that you start to feel the whiplash. And so I would expect that as things start to go back towards this new normal, that we're all going to be hit with it. That we are going to feel that whiplash in the months to come, and to expect that and to create support systems for ourselves, which gets to the next part of your question, Esteem, which is how can our families support our students and each other? I've said throughout this pandemic that one of the best things that we can do is to reach out to our loved ones and to make sure that we connect with them in whatever way we can, whether it's over Zoom or phone call or text or TikTok, depending on what age your kids are. But that becomes even more important as we get out of this pandemic, because there's, just as it was jarring to go from pre-pandemic to that lockdown phase, it's going to be jarring and anxiety producing and again, emotional for folks to come back out of this. And so the imperative to reach out to each other does not go away as we go back to the new normal. And in fact, many of us are expecting that we're going to see a rise in mental health problems as things lift. We saw a rise in opioid overdoses when shutdowns were lifted, and I expect that we're going to see a rise in mental health problems over the next few months as well.
Thank you. I think that really is a critical part of the conversation, that we want to be able to balance an optimism, but a realism. I think, as Dr. Fauci often says, pragmatically optimistic moving forward. I was curious if you could answer a couple questions around how the pandemic has changed our approach to data collection and our relationship with technology moving around. I know early on we had some stumbles in how we collected data, how we analyzed data, particularly that affected communities of color and immigrant communities. Maybe if you wanted to start us off, Dean Jha, with how you see we have improved our data collection in response to the COVID.
Yeah, boy, where to begin on this? This has been, on one hand, like one of the biggest disasters. On another hand, one of the huge highlights. And so let's talk about all of that for a second. So for much of this pandemic, the federal government just could not pull together data in a way that was meaningful, that was understandable. There were substantial failures at the CDC on this. We were pretty blind to the whole racial ethnic impact of this pandemic and the disproportionate impact on minority communities for months. And that was largely a data problem. And there obviously wasn't only a data problem, but it was the blindness was largely a data problem. And state health departments have really struggled to keep data together. And what's been really interesting is, who's really pulled all the data together in a way that was nationally coherent and allowed us to work together was something called the COVID Tracking Project, which was run by a bunch of ragtag group of journalists. And I say ragtag with affection. I mean, these were amazing people, hundreds of volunteers who every day spent hours and hours pulling data together from lots of different sources to create a coherent national picture. The White House relied on the COVID Tracking Project to understand what was happening with infections around the country. So on one hand, like that's the data disaster of a country that was largely blind, could not figure out how to pull it together, and relied on data from a group of journalists. But there have also been some really interesting innovations. So throughout this pandemic, when I think about every day, when I look at data, try to figure out what the status of things is. Yes, I looked at COVID Tracking Project data. I also looked at Google mobility data. I looked at open table reservations data. You may be thinking like open table reservations to understand like where to have dinner tonight. No, like there's publicly available data on how many reservations people are making at which restaurants across the country. It's actually a really smart, like a really powerful insight into people's thinking and behavior, their risk-taking, kind of how comfortable they feel dining indoors. And you could see open table reservations dropping before states would go in and put in restrictions on restaurants. So it was a leading indicator, not a lagging one. It made you realize there's all of this data out there that actually can teach you a lot about what's happening in a pandemic that we don't traditionally think about as public health data. I think that's going to be one of the huge kind of innovations, transformations coming out of this pandemic, is we're not going to just rely on Department of Public Health data for health issues. We're really going to start using a very different and much richer set of inputs into understanding what's going on in a community or in a society.
Dr. Ranney, did you care to jump in and speak to maybe innovations that you see moving forward around how we collect data, how we use it, how it can support our technology to address public health issues?
Yeah, I mean, again, I think that probably Ashish and I could talk for 2 hours just on this topic. It's something that we both care deeply about and see as really a key driver of the public health enterprise. Is we can't do anything. That's like step one of public health, is having good, reliable data. Just to take kind of a high level view of it, I think one of the most remarkable things about the pandemic from a data perspective was the degree to which people moved quickly to do things which they always said could not be done regarding data and digital innovation. From the relatively simple stuff of the government saying we have to reimburse telehealth visits at the same rate as in person, and we're going to remove some of the very stringent security requirements that prevented healthcare providers from doing telehealth visits with their patients through FaceTime or Skype or Zoom. Those were removed during the pandemic, which allowed telehealth to blossom even in institutions that had never really embraced it before. Two, things like, as Ashish said, changes in the way that we collected and shared data. Our own Department of Health, when I look back to a year ago, I was having to fill out a paper form, fax it to the Department of Health, and then get a faxed result for every COVID test that I ordered. Back right in 2020, we were relying on faxes for the results. And then someone had to go and collate them into Excel spreadsheets. Now it's all automated. And so the pandemic has forced departments of health and other institutions to really modernize. It created the funding, but also the imperative to do that. We also saw a huge surge in interest in digital health innovation. Again, it was forced out of necessity. There were very few in-person visits for anything other than my emergency department in the early days. But some of the companies that we've worked with through the Center for Digital Health have seen a huge boom in customers over the last year because health departments and patients and populations have recognized that there really is value to having remote care and remote monitoring in ways that they had been reticent to engage with before. The last thing is that I think that, again, this pandemic has shone a light on some of those divides that we've often glossed over. And I think there's no better example of this than the vaccine rollout, where many states relied on websites to allow people to sign up for vaccines. They didn't plan appropriately. I made the analogy early on that I felt like it was getting a ticket to a Taylor Swift game or to a Taylor Swift concert, right? Like you would sit and sometimes not come up at the end with a vaccine appointment. They also weren't designed for the elderly, who were the first folks that we were rolling vaccines out to. They didn't take into account all the stuff that we know about making font sizes bigger, about making them easy to navigate. They weren't designed for mobile sites. We know that most folks that are low income rely on their phones for internet access. And so if we want to address the digital divide, we have to talk about making things mobile. So I think there's a lot around data and design that has, again, been highlighted during this pandemic, especially by the vaccine rollout. It's not that technology is not available to folks who are lower income or elderly, but it's that we have to use it and design it intentionally.
Thank you for that. I think that's a great point you raised. I wanted to bring this back down now to a university or public health department level for our campus. You addressed a couple of issues around race and equity around the new normal of the pandemic. I'm curious to know how that might be reflected moving forward in our courses. How will we see changes in our syllabus or how the department approaches the topic of race, equity, and inclusion, or how we approach public health? Dean, did you want to start us off?
Sure. So we've, for a long time at the school have had, I think, a pretty substantial focus on on racism as a public health problem. But we've certainly gone back and not just thought more about racism as a public health problem, but how this pandemic should be taught as part of public health. Because the pandemic has kind of exposed all sorts of public health issues, right? From the epidemiologic to biostatistics to behavioral health, all the things that we teach, the pandemic has direct relevance. So I think on one hand, it's making us look at the entire curriculum a bit. But second is it is asking and forcing us to ask some of those more difficult questions about how do we work equity into all of these conversations. Do I think it's going to happen perfectly? No, but we are pretty committed to looking at what we teach and how we make sure. And the issue is really straightforward in my mind, right? We are training public health leaders. They need to go out in the world and solve big public health problems. If they don't understand the underlying structural issues that create inequities, they're not going to be very good at their jobs. And so we need to prepare them to be effective public health leaders. So this is not out of some broader desire for equity, though we have those desires. This is just about effectiveness. It's about making sure people understand the issues that cause the kinds of public health problems we see, so that as public health leaders, they're much more effective at addressing them.
And for you, Dr. Ranney, how might the pandemic change the way you teach? I mean, that's a broad question. I guess I can narrow it down. I think that moving into 2019, there was so much promise and hope for online learning as a platform. We had more momentum than we've ever had before in terms of it being supplemental, really being a strong teaching tool, not just in the United States, but globally. Having access to internet and having access to online learning fundamentally can change communities and the trajectory of their life. One of my fears is, given COVID and online learning, and particularly what we call a Zoom fatigue, where do you think moving forward our relationship with online learning will be as a community, and where do you think it should be? I don't want, obviously we want to open up our classes and be in person, but we also don't want to lose this amazing tool that we have.
One of the things that I hope to see coming out of this pandemic is some really great educational research around where online learning is most useful and what styles of online learning or kind of teaching are the best versus which ones can go the way of the dodo when we get through this acute phase of the pandemic. And I think that all of us have seen examples of great remote teaching and really bad remote teaching and learning. I know that there are folks here that are doing that work. Certainly, Dean Jha and I in our pandemic problem solving course, which I know that you've been one of our facilitators for, we've learned a lot through the process about how to create interactivity, around how to create engaging opportunities when you can't kind of look at the classroom and get immediate feedback and do immediate Q&A. I will say there have been a lot of great strengths, and a very recent example on Thursday, one of my seniors defended her thesis, and her parents, who live in Detroit, were able to join us because we did her thesis presentation and defense remotely. And it was so awesome, both to get to meet them and to be able to have them engage, and to be able to have folks from my lab who are literally across campus and also living across the United States right now because of the pandemic, to have all of them be able to join. That would not be possible when I look back to 5 years ago when I had my students defending their theses. We were in a small room with like 3 people. And so I think it opens up the potential for cross-sectoral innovation and communication. And it also, although it can certainly worsen inequities, it can also overcome some problems and barriers to folks engaging in education, as you mentioned, from kind of the global sphere. So it's tough to say right now what's going to stick. As Ashish said, I think there's going to be some aspect of remote learning which we maintain. We have seen a lot of great opportunities for engaging larger groups through using innovative online learning platforms. But again, I expect there's going to be a new pedagogy around it that comes forward in the next year or so.
Can I jump in on this a little bit?
Yeah.
Couple of thoughts. I mean, one is there's been a movement towards online education that I think is really important, but we have not quite figured out how it fits into the broader educational landscape. And I think about, before I came to Brown, I had put together three what are called MOOCs, massive open online courses at Harvard. And one of them, it was entitled Lessons from Ebola, Preventing the Next Pandemic, was a course I put together in 2015. We probably had about 15,000 students take it in 2016 when it ran for the first time. And we had an additional like 70,000 students take it this past year, right? Because it was a course that talked all about the pandemic that was coming, what to expect, how to prepare. And we put that course together in 2015. But what's the point of that? The point of that is, first of all, when you look at who took that course, the fact that one course I put together had 100,000 students who took it, I've probably taught more people in that course than my entire life combined, right? I haven't taught 100,000 students. Second, a large chunk of those students came from outside of the United States, people who would otherwise never have access to that kind of information. Third, it is, in some ways, it's not evergreen. It probably needs to be updated. Well, it will need to be updated at some point. But the idea that you could pull off a course from 4 years before and make it available. I really have been thinking a lot about where is the Brown School of Public Health's educational mission going. And I believe that obviously we have to provide a fabulous experience for students who are here in Providence. But I also believe that Brown should be educating people, and let me clarify this point once I make it, should be educating people who never stepped foot in Providence. And that doesn't mean we should be offering online degrees. We could offer online degrees. I'm not opposed to that. But we should have a whole set of educational offerings for the world. And the desire for public health education is going to be so substantial. And it's not clear to me that the only way people should have access to Brown education is by coming on campus. And so it can be, and again, it doesn't have to be degrees. It can be all sorts of different ways of connecting. But I think that's really important for universities. And given especially the hunger for public health education that is so massive around the world right now. People want it, they deserve it, and we should figure out how to offer it in a way that helps people make better decisions and be more educated about what's going on.
Thank you so much for that. I'd like to turn now to questions from the audience. If you have a question, please feel free to submit your questions in the Q&A. We hope to get to as many as possible. The first question we have is sort of a question maybe aimed at you, Dr. Jha. Why do you think the rates of COVID are declining?
Well, so nationally, presumably in the US, and they've sort of flattened out over the last week. So the cases of COVID in the US peaked around January 12th or so. And then they did this very sharp decline. And to be perfectly honest, anyone who tells you they know exactly why they declined as precipitously as they did is making it up. None of us know for sure. I believe there are three major factors that have kind of contributed. One is we have a lot of population immunity. We've had a lot of people get infected in our country. And at some point, the level of infections got high enough that it started having a population effect. Second, and this is going to sound a little strange, but I really do think the seasonality of the virus started helping us in mid-January. Now, the strange part is mid-January feels like a little bit of a funny time for seasonal benefits. But if you look at this virus, if you look at all coronaviruses, there are lots of coronaviruses that circulate among humans. They tend to they peak in December and start falling in January for reasons that we don't fully understand. So there may be that this coronavirus is acting like other human coronaviruses. So those are two. And third, I really do think after coming off the holidays, it was people weren't traveling as much. There was a lot more. There was a bump up in mask wearing. You could look at things like open table reservations data and see a drop in people going to indoor dining. That there were behavioral changes. And all of that put together, I think, drove things down. We have flattened in the last week, and we have about 15, 17 states where the cases are going up. And that's all, in my mind, B117, the UK variant. It is now so substantial that it is like really starting to have a big effect. And in Europe, we've seen massive surges. As I said earlier, I don't think that'll happen here if we are smart, but we're not necessarily being all that smart. So I think the next few weeks are going to be difficult, and we may in fact see cases starting to rise. It's basically B117 versus how quickly we can get people vaccinated. And obviously things are going well with vaccinations, which I think is helping on hospitalizations and deaths, but infections are going to continue going up for a while.
And Dr. Ranney, what actual causes of death of COVID patients have physicians been seeing? And have they changed over the year?
So they have not substantially changed over the year. So, an important thing to remember about COVID is that although we have a few treatments now that help a little bit, there are no cures still for COVID. We do have monoclonal antibodies, which if given very early in the course, after a diagnosis, can help reduce emergency department visits and hospitalizations. But by the time someone shows up in my emergency department, dexamethasone, remdesivir, they really don't do a ton to change people's course. When I look at the causes of death of folks that we're admitting, it's a few different things. So the first and biggest one is respiratory failure. COVID causes a horrible viral pneumonia, causes just horribly low oxygen levels. And that's really the driving cause of death for many folks. We have learned over the course of the pandemic how to try to put off invasive ventilation, so putting someone into a medical coma, putting a breathing tube down, breathing for them, using a machine as a ventilator. We've learned how to put that off for as long as possible. But at the end of the day, some people just can't keep their oxygen levels up without that. And that's a driving cause of death. Beside that, COVID is this unbelievably wily virus that causes inflammatory cascades across the body. And so we also find that it causes things like blood clots. It causes damage to the kidneys. It causes damage to the brain. And so we see people that die from all of those as well. And not necessarily during the acute COVID period. Sometimes it's after the initial infection has resolved. So I see a lot of folks that come in 10, 14, 21 days after their initial diagnosis and now have had a heart attack or have blood clots in their lungs, have a myocarditis where their heart isn't squeezing right, or have kidney failure. And that then drives long-term disability or death as well. There is, of course, also long COVID, which is something that we know very, very little about at this point, other than that it does seem to affect a subset of folks. We have studies from early in the pandemic showing that people that were hospitalized with COVID continue to experience trouble breathing, fatigue, and neurological symptoms for months afterwards. We know that that happens for patients who are admitted to the ICU in general, even people who don't have COVID, right? There's a post-ICU period. But COVID seems to be a little different. It seems to be causing symptoms in people who even weren't hospitalized. I'll say my own sister, who is a Brown graduate and is a physician practicing in Switzerland, she caught COVID as part of her normal practice. She is still months later cannot smell, simply cannot smell. And it is this still unexplained mystery of why COVID attacks the olfactory nerve, why months later, after she's otherwise fully recovered, she's going skiing and doing her normal stuff, but has no sense of smell. And those types of things we're still very much trying to figure out. There's going to be a huge NIH initiative to try to investigate that better. And of course, there's going to be a big NIH initiative to help us develop better therapeutics, although I don't have a lot of faith. We don't have great therapeutics for most viruses that are out there. The fact that we have vaccines, that we have these marvelously effective vaccines in and of itself is just extraordinary, an extraordinary testament to the value of science and to the value of government investment in science and research.
And in terms of the long-term health effects, have we seen a difference by age group? Are students any less likely to have long-term COVID effects than someone in an older age group?
The research on it is, so, there's anecdote and then there's data, and the data is still really too new to be able to say kind of with certainty. Most of the studies that are out there are convenient samples. So it's kind of people that happen to see a survey and happen to take it. We see it a lot among like 30 and 40-year-olds, a lot among women, which is what we see with many post-inflammatory and autoimmune conditions, right? So similar to thyroid problems or lupus or chronic fatigue syndrome. We're finding similar patterns right now, but it's tough to say how much of that is really because of the virus versus who's participated in the studies that have been published. Current reports say that long COVID is less common as you get younger. But again, I wouldn't want to hang my hat on that yet, just because the research is still so new. I would say that for college students, still the most important thing is kind of mask wearing. Luckily, college students will be eligible for vaccine soon, given that the vast majority are age 18 plus, and then some can get that the vaccine that's been approved for age 16 plus. But I wouldn't write off dangers just because you're younger. But again, the current data says you're probably a little lower risk for long COVID, but I just wouldn't hang my hat on it.
Sure, that makes sense. And Dean Jha, what can you tell us about the new variants that have emerged, and what should we be looking at moving forward in terms of them?
Yeah. So there are many of them, and there are at least 4 that I think are in people's minds. The ones originally from South Africa, originally from Brazil, originally from the UK, and then the one originally from New York. And there are others as well. And we can talk about the one that was originally identified in California. I instead of going through every one of them and everything we know about them, here are a few principles. One of the things that we know, almost every one of them look like they're more contagious than the SARS-CoV-2 virus that was circulating in the fall and winter. B117 is clearly a lot more contagious. That's the one from the UK. So the big question, of course, everybody asks is, what about our vaccines? Are they going to hold up? And the way to think about it is, your immune system is not an on-off, like, does it work, does it not work? It's really about gradations. So for B117, the UK variant, our vaccines look terrific. All 3 of them that are out there look like you're going to do very well if you've been vaccinated. On B1351, the one from South Africa, the one that has the greatest amount of immune escape, I think we're going to see more breakthrough infections. We're going to see vaccinated people getting infected. But breakthrough infection is not great. It's not what we want. But what we really care about is protection against severe illness. And everything I have seen in the data from Johnson, and particularly from Johnson & Johnson, where the data is the strongest, but also from Moderna and Pfizer, suggests that these vaccines are going to hold up very well in preventing severe illness against B1351, against P1, against the New York variant. So the key to beating the variants is getting lots and lots of people vaccinated as quickly as possible. And by the way, last point is that we should not assume that we're going to be done with the variants. We will see more variants come around. And all of these variants have arisen in 1 year of this virus circulating. And one of the reasons why I and others have been pushing really hard to get global vaccinations going and moving is because I don't know that I feel that lucky that we should just sort of let this virus run wild for the next few years. It would be awful for the world, but it also gives the virus a lot more chances to essentially create new variants, including one that may eventually defeat our vaccines. I'm hoping that will not happen, but the best way to avoid that is to get as much of the world vaccinated as quickly as possible.
And what are we doing to build confidence around vaccine use? Dr. Ranney, I saw that on Twitter the other day that you retweeted someone who is vaccine hesitant. This was the first time that they've ever gotten a vaccine. And I thought that was such a beautiful tweet, such a beautiful thing to see someone who all of their life had been afraid to take a vaccine is now choosing to do it. And I think you said that they were very courageous. How do we build that courage in society? What does public health need to do to build the message of get the vaccine?
Oh, I love that. Yeah, that was the coolest. So the thread, one of my favorite things was that you looked at her tweet, which I had kind of responded to early, and there were literally hundreds of responses from people saying, I was afraid too, and I got it. And, these are all the ways, and then that it helped. And then people talking about how you're helping to support your community and talking about how the side effects are really temporary and talking about, of course, the ways in which we can trust the science behind it. So I think that we as public health professionals have a couple of roles. So the first is to listen. And certainly as a healthcare practitioner, it's what I do or try to do all the time when I'm engaging with my patients. But I think that those of us in public health as well, it's to listen and to not dismiss people's fears, because many of those fears are well-founded. They're addressable, but you can understand why they have them. So you can listen, and then you share facts. You can share also stories, which make a big difference. So that's the first thing. The second thing is to engage our communities. we know in public health that the very best thing next to facts is having credible messengers to deliver those facts. It's about having people that are trusted within the community to share the message that vaccines are both trustworthy and effective. And so our engaging folks who do hold that role within their communities is critical. The third thing is increasing access. There was a lot of talk early in this pandemic about how, Black Americans were vaccine hesitant and weren't going to get the vaccine. Well, it turns out that when you make the vaccine available at similar rates to predominantly Black communities in the United States, the uptake of vaccines, whether it's COVID or flu or any other type of vaccine, is the same as or better than in white American communities. The difference is just lack of access. And so I think that often we kind of dismiss people as being vaccine hesitant when it's really an issue of not being able to actually get their hands on a vaccine. And I think that's on us in public health, going back to the question that you asked much earlier about what we can do to continue to address equity. That's on us to keep an intentionality behind equitable distribution. When you look at the states that opened up vaccine access to everyone earlier, who said, oh, well, age 65 plus from day one, they have higher rates of inequity in distribution of their vaccines than in states that perhaps took it a little bit slower and had greater intentionality behind equitable distribution. It's, of course, constantly a struggle between speed and equity. You don't want to give up either. So I think that those are the three big things. I'll say that we're working with, Ashish and I and others within the School of Public Health are certainly working hard on vaccine confidence projects. There are a lot of great efforts ongoing across the country with local community groups. And I think that that's also on all of us to help engage in and support and amplify those voices to improve confidence.
And Dean John, our final minutes, what are your thoughts on the future of public health and public health education moving forward?
It's pretty bright. I mean, look, for years we have underinvested in public health, and I think we have now come to realize that that underinvestment was not very smart. And so I expect a lot more attention on building out a public health workforce that is ready for what will come. And what is going to come is more public health crises. I think I've said this in multiple forums that we really are entering an age of pandemics. We should expect more pandemics in the future. There was a reason I put together that course in 2015 in which, and the irony in that course was I asked everybody who participated, I would ask them all, okay, imagine it's 5 years from now, imagine it's 2020, and there's a global pandemic. Will the world be ready? Now, did I know it was going to be in 2020? Of course not. But it was very clear that we were at risk. That risk hasn't gone away. So I expect a lot more investments, not just in pandemic preparedness, but in public health more broadly. And then, of course, a lot more interest in public health education. Public health schools have seen about a 20 to 30% increase in applications. The Brown School of Public Health has seen about a 110% increase in applications across all of our programs. I think it's a pretty exciting time to be going into public health. You get to work on really important issues. And so I'm thrilled about that, of course, and think that Brown has a really important role to play in educating the next generation of public health leaders.
I agree. I couldn't have chosen a better time to come into public health and come to Brown. I didn't know when I put in my application that a pandemic would hit. So this has been a very informative and learning experience for sure. We have a couple minutes left, and so I wanted to offer you an opportunity for closing thoughts. Did you care to start us off, Dr. Ranney? Any
Sure. So to closing thought, just to echo off of what Ashish just said, I think that when I look forward to the future, what we take away from this pandemic and where we go next, I hope that we take all of the lessons that we've learned about the value of connectedness, the value of public-private partnerships, the value of investment in science and research, the value of community, and of course, the value of public health and of data and of equity. I hope that we take all of those and don't forget to apply them, not just to preparedness for infectious disease pandemics, but also to all of the other health challenges that our society here in the United States and globally face. I think that we can take so many of the things that the three of us have talked about over the last hour and apply it equally well to colon cancer or diabetes or violence or mental health. And I think that that's on us to continue to insist that we don't forget these lessons and to make sure that we use them to create a more equitable and healthy society going forwards. And I'm just so honored to get to do this work here at Brown and with all of these amazing students. I've been here since 2004 and am just so grateful to be part of this community and to have such incredible students to work with. So a big thank you to the families for making it possible and for supporting your kids in getting them here. So.
And let me add to, difficult to add to Megan's comments, but I'll just say a couple of things. I saw in the chat a lot of questions about vaccinations and what's going to happen on campus. And there's a lot of details coming, but the big picture point I will make on that is, as you might imagine, the university is pretty focused on making sure that our faculty, our staff, our students have access to vaccines as quickly as possible. So there's a lot of work being done behind that. And it's a fluid situation because obviously we work with the state and the state gets to make decisions about a lot of this stuff. But for people who are wondering, is Brown going to be proactive in making vaccines available to our community? And the answer is absolutely, but working very closely with the state to do it in a way that's reasonable and fair. Last point is, pandemics throughout society, throughout human history, have had these profound effects on how society is structured, how society functions when people recover from these pandemics. The last year has been horrible. I mean, it's just been horrible. Almost 550,000 of our fellow Americans have died. Millions of people have gotten very sick. And it's been horrible for the world. It has thrown, by best estimates, 150 to 200 million people into poverty. It has just been a very bad year. The next year is going to be much, much, much better, like much better. We've got so much to look forward to. It's not going to be all normal. But the point I want to leave people with is that this is a very specific opportunity and a very specific moment that we have where we get to reimagine a bunch of things, that all of the constraints that make change so incredibly hard have all loosened up. And we have an opportunity to ask the fundamental questions about what kind of society we want to live in, what kind of country we want to have, how we want to raise our kids. There's a set of value questions that are very hard to deal with when you have kind of forces for status quo that make change difficult. Those forces of status quo really are much weaker right now. And I think we need to use this moment to really re-envision public health, healthcare, well-being, how we connect with each other, the role of technology, all the stuff we've covered. We get to remake this. And it's us who gets to do it. And now is the moment. Now, the next 3, 6, 12, 18 months, not 10 years down the road. And so we've got to use this opportunity to come up with a much better country and a much better world. And that's what I'm excited to do here. Unlike Megan, I'm really new to Brown. I came in the middle of the pandemic, but I have to say I'm loving being here. It's a phenomenal community. And I'm excited to work with the community to re-envision what the world could look like.
Dr. Ranney, Dr. Jha, thank you for joining us today. We really appreciate it.
Thank you.
Thank you.
Bye, everybody.
Bye, everyone.